Yeah.
So,
Okay, awesome. All right, so we are running a little bit thin on our attendance today, but like I was joking earlier, maybe people are playing outside because it's a really gorgeous day. So we'll go ahead and get started though, for the sake of time. And I know lots of people are waiting to join, especially the open mic session as well, so I don't want to have them wait. I will go ahead and introduce myself. I am Dr. Sonia Hirachan. I'm the Executive Director and Medical Director for Forensic Services within Direct Care and Treatment, and one of the co-chairs for this task force today. And I'm really excited to welcome you all to this meeting today. We have a pretty packed agenda, and I am going to go have people introduce themselves. First up is Sue.
Sure. Hi, everyone. Sue Apperholm, Executive Director of NAMI, Minnesota.
Kevin Modi, Director of Patient and Family Engagement from Forensic Services.
Lisa Harrison Heather, I'm the Ombudsman for Mental Health and Developmental Disabilities.
Carrie Gallagher, Executive Assistant for DCT General Counsel's Office.
Ian Zimmerman, Assistant Ramsey County Attorney. I'm here on behalf of the Minnesota County Attorneys Association.
Dr. Amber Lindeman, I'm a court-appointed examiner.
Megan Larison, an attorney with Direct Care and Treatment.
Cassie Sassenberg, Health and Human Services Director in Nicollet County. I'm here on behalf of NICSA.
Awesome. And then, yes, we do have a member of the public.
Do you want me to introduce myself now?
Yes.
I'm Kathleen Beto. I am the mother of a son who was committed in St. Peter State Hospital for many years and just returned voluntarily in May of last year. So I'm new from the camp. So thank you so much for setting this up and for inviting me and the other people who are coming to speak today. Really appreciate it.
Thank you for being here. Next up, we'll go to folks on video. I know we have a number of people. Let's start with Marshall.
Hey, good afternoon, everyone. I'm Marshall Smith. I'm the Health Systems CEO for Direct Care and Treatment.
Marshall, I know Dr. Stevens, you're online as well.
Yes, good afternoon, everyone. Kylie Stevens, Executive Medical Director at DCT.
Thank you and welcome. And then we have Dr. Adi as well online.
Hi, this is Kristen Odie. I'm an examiner with Psychological Services in the 4th Judicial District, and I also serve on the Special Review Board.
Great to have you here, Dr. Adi. Thank you. And then we also have a parent here, Sheila.
Yes, hi. I am the mother of a son who was at St. Peter for 12 years and was provisionally discharged about 3 years ago.
Thank you, Sheila. Is that all?
Mike Bigelow just joined. Yep.
Welcome, Mike.
Hi, good afternoon, everybody. Sorry I'm late. I just finished up an SRB hearing. So my name's Mike Bigelow. I've spent decades representing those in the mental health system, and I'm very happy to be a part of this group. Thank you.
Thank you for being here, Mike. Anyone else, Carrie?
Matt Freeman.
Matt Freeman, do you want to introduce yourself?
Sure. Matt Freeman, the Executive Director of the Minnesota Association of County Social Service Administrators and a Human Service Policy Analyst for the AMC Association of Minnesota Counties, and here in support of our appointees.
Awesome. Thank you. All right, so we shall go ahead and start with our agenda today. I know we have talked quite a bit about our work groups. You know, we've divided this big task force into a number of work groups. So the first two work groups were working on a couple of objectives. The first work group was working on objective 1 and 2. And just to refresh people's memory, objective 1 was to analyze current trends in MI&D civil commitments, including but not limited to the length of stay for individuals committed in Minnesota as compared to other jurisdictions. And then objective 2 was to review national practices and criteria for civil commitment of individuals who have a mental illness and represent a danger to the public. And the members for this particular work group was Dr. Holden, Dr. Griffiths, Blunt, Dr. Dugan, Megan Larison, Delane Ramus, Ginny Palin, and myself. And I know that this work group has collected some data, so I'm going to let Sue kind of go through the work that we've done.
Sure. So we have a draft document. The group hasn't come together to, kind of fluff it up, and make sure it's, all accurate and kind of fits together and things like that. We were able to get data, in terms of current trends in Minnesota. So in 2020, there were 55 MI&D commitments filed. It went up to a high of 63 in 2022, and in 2024 it was 57. So it's kind of stayed around 50 to low 60s. And when we look at the other commitments, that has stayed not quite as stable in some ways, but so there were 4,642 in 2020. And then it went up in 2021 to 4,909, and then back down to 4,577 in 2024. They looked at like which counties. So Hennepin County filed 25% more MI&D commitments in 2024 than it did in 2020. Setting aside Hennepin and Ramsey, St. Louis County consistently filed more MI&D commitments than other counties between 20 and 24. And then the remainder of the counties sampled were between 0 to 3 per year from 2020 to 2024. Statewide, MI&D commitments have increased 77% since 2014, which is important to know as well. And then the very biggest increase was in, doesn't quite make sense, 2020. Anyway, so we need to kind of, still kind of go through that. And then let's see, we also looked, and then there's a lot of data that was put together, which was great. We also looked at what was happening in other states, and what we found is that trend lines show a 76% increase in the number of forensic patients in state hospitals from 1999 to 2014, although it's not consistent across all states. So we're able to find, some reports that talked about it, but to be honest, nationally, it isn't like there's a repository of, all the commitment data. So that actually kind of made it kind of hard. We did go through and looked at national practices and criteria for MI&D commitments. And I think, as we all know, Minnesota has 2 separate categories and most states do not. And so that kind of sets us apart, definitely. We did look, the Treatment Advocacy Center had issued a report called Grading the States, an analysis of the U.S. psychiatric treatment laws. Their full report, there's no reference at all to something that we would call an MI&D commitments. So that also made it kind of hard. But we did look at the definitions of danger to self or others to kind of see what their definitions were. So we did pull those out into our draft report. And then we pulled out the summary, and then we actually pulled out the actual language from the National Council for Mental Wellbeing, so we could see what their actual language was as well. So we have like Alabama, Alaska, Arizona, Arkansas, California, Colorado, Delaware, Connecticut, Florida, Georgia, which I think will be helpful in the next group. Hawaii, Idaho, Maine, Illinois, Massachusetts, New York, Michigan, Wisconsin, and Texas. And then we looked at, made a lot of stuff here. Yeah, it is kind of big. The key finding from the review is that while Minnesota employs a single civil commitment-based pathway to long-term secure treatment, other states employ a patchwork of 3 main avenues with relatively high barriers to entry when allocating secure treatment resources. So I think that's one of the things that we really need to look at, that we are really doing it a lot different than other states, and what can we learn from them as well. Let's see, post-conviction carceral systems vary in their resources to meet the needs of this subpopulation. They did say that most of them have, sorry, all that cold, and I don't know about your house, but mine was not humid at all. It do have some form of specialized residential treatment units for these populations. So, we'll send this out to folks so that they have it in front of them. But But I think, and none of us have read it all because it all just kind of got put together, pushing people to put their sections in. So, but I think once we kind of meet again and kind of flush some of the stuff out and make sure it's all going in the right directions, I think it'll be helpful. But the big takeaway is other states don't do it like we do. I don't know any of the other members of the group if they want to add anything.
Yeah, I think so after reviewing the literature from all over the country and looking at how differently we employ this civil commitment for indefinite commitment, I think the broader understanding is that again, since Sue said, we are the only state that employs this method, just this one method for indefinite civil commitment, this one pathway, basically. Whereas other states have a couple of other, ways of doing indefinite commitment. And so there are advantages and then there are disadvantages, right? Advantages being that it's pretty straightforward and it's broad. The disadvantage being that it is, again, straightforward and it's broad. So there are, catches to all of this. And so we're hoping to be able to, again, distill the recommendations and then take these recommendations, move forward with the other work groups that are being set aside. So we're really hopeful that we can do that.
So this work group will meet kind of once more to kind of everyone walk through all the information that's been compiled. And make sure that the language everyone agrees to and things like that. So, but thanks to everyone who sent their information in. It was really hard to find some information out there though in terms of other states. That part was not easy at all. There weren't many national reports.
Any questions? We'll make sure that folks here have a report of the draft that we have. Any questions from folks on video? Okay, not hearing anything. We'll move ahead to our second work group that was on objective 5 and 6. And 5 and 6, those were the objectives to identify what types of placements and services are necessary to serve individuals committed as MI&D in the community. And then to make recommendations to reduce barriers to discharge from the forensic mental health program for individuals committed as MI&D. And the work group members were Cassie Sassenberg, Sue, Sheila Novak, Ginny Palin, Lisa Harrison Hadler, Ann Zimmerman, Dr. Lindemann, Becky Robinson, Robin Bodie, and Jennifer Karlstrom. So I'm going to let Cassie Sassenberg here take away.
Sure, thank you. I think we feel similarly that we aren't quite at the report out with our recommendation stage. I think
If people talk a little louder, because it's kind of hard. I don't know, we're not supposed to hear.
You can hear. It's an open meeting.
Oh,
You can
yes.
hear.
Oh, can I hear? Okay, yeah.
We'll talk louder.
Yeah, because we want to speak from here, you know what I mean, or,
Yep.
thanks so much.
So we're thinking that we need 1 to 2 more meetings as well to really flesh out our recommendations. We've been trying to look through data that we've received. So we participated in that Friends and Family survey that was completed. We had a survey of human services directors, a survey of county attorneys from elected as well as their mentally ill and dangerous committee, or is it civil commitment committee?
Civil commitment committee.
And then some community residential providers as well. We're thinking we still need a little bit more information from, we're hoping from like the judicial branch as well as from examiners before we can really solidify things. So we met yesterday and we talked through sort of some of the highlights that we've seen and tried to brainstorm the start to our strategies. So for placement types and services necessary for the community, we really focused on the process prior to final commitment, as well as alternative options in lieu of the forensic mental health program. Noting that in statute, that's a possibility if there is an appropriate placement allowed, but identifying as or available, but noting that as a group and based on the data that we've gotten from our other groups, that we don't really feel like there is a placement that exists right now that does what would be needed. So as we started brainstorming, like what what is needed, what do those things look like? And we talked about really seeing it be a priority for there to be state-run options, because there's been a lot of privatization, which allows for a lot of no when we are asking people for a placement. Placement lists are long. Usually people who we're talking about, are experiencing a lot of difficulty. They have illness, there's behaviors that occur. A lot of our providers, that's not something that they accept when we're making referrals. Or if something happens, then it's quick to discharge. So we were talking about this needing to be a facility that could be used long-term and could be something that we could rely upon. We haven't started talking about where that might be, but in prior conversations, we've talked about regional needs. We know that we can't have everything local to each county, but different parts of the state would be preferred. We talked about using this placement type for a few different things. It could be utilized to provide safety assessment and treatment. So in some situations, this could be done instead of an MI&D commitment being finalized. So an opportunity for somebody to have a safe place to be stabilized, receive treatment, and then have that assessment process to determine whether that's needed. So that could be a part of MI commitment where maybe we've had an extended commitment or numerous commitments. This could also then be part of continuing a hearing for up to a year. That's allowed in statute, but there isn't always a place for that to occur. Right now, that might be happening in a community hospital or in a jail, and that doesn't feel appropriate. So that was a second use for this type of facility. And then we thought that this could also be an alternative for somebody who does have a final MI&D commitment type, though we would want to explore more when would this be the appropriate setting. So that part we have more discussion to have. We talked about general things about the facility, making sure that it is offering mental health treatment, psychiatric services, and therapy, flex locked or locked cameras, staffing, the ability to enforce driver's orders. We started going into the thoughts about funding, but we're just dreaming in this section. This section didn't require the funding. So we did mention accepting MA or ongoing benefits just because we know that in our jails that isn't the case. And so we wanted to make sure here that medication could continue. And we talked about also part of the facility being able to transition people back out into the community as well. We also talked about how mental health services being provided in our jails is not our preference. We don't find it appropriate for people to be in the jails long term. But we did talk about how if people are going to continue to be in the jails at times, we would like to promote the jail consultation services to ensure that people have access to the medication that they need in the jails. And then looking at that second piece where there's funding back to jails in local counties right now is that pilot to be able to offer that medication without direct cost to local counties. We've talked a lot about just how people decompensate in jail, how that isn't the appropriate place for people to be, and how if that could at least continue while they're there on the way to somewhere else, long-term success would be better. We talked about final commitment as a whole, starting to brainstorm like where should that occur? Could that occur at this facility that we would like to envision happening? Could it be at Anoka Forensics? Should there be discussion about that not occurring in jails or hospitals? But there were a lot of questions that we had about that. In what cases would it get extended? Who does the evaluation? What's the reasonable time period? Things that maybe were outside the scope of our group, but that kept coming up in discussion. For objective 6 with the reducing barriers to discharge, we had a lot of ideas here. And so this is another one to continue the discussion. We talked about case manager involvement and based on the knowledge base that somebody might have, depending on the county that they're at, this might be their full caseload, or it might be something that they do one time in their career. And so providing case management and understanding the MI&D process is not always existing. So we talked about strategies for case managers to attend meetings at as the designated agency. We started talking about provisional discharge plans and roles, and so I think we're going to talk more about that. We talked about having CIS involved. Jenny talked about how they could be more involved and perhaps for longer amounts of time. And so we were having some discussion about how that would be identified, depending on the county and their knowledge and their, maybe the proximity of the individual to the county that's providing the case management, maybe a process for that to be identified at discharge. We were dreaming again about regional medication options. So if somebody's struggling in the community, CIS being able to check in with them, but also like, could there be an option for somebody to be able to offer medication outside of clinics, like more at the site a person is located?
And just to interrupt you so that folks are aware, so CIS is Community Integrated Services, and that is a program that Forensic Services has that really helps people, you know, with an MI&D commitment in the community. So that people are aware of what CIS stands for.
Sure. So a lot of that section really felt focused on maybe how the counties and CIS partner together upon discharge, because that kind of section came up in many of our groups of feedback. So Jenny and I are going to meet, we have a couple of times flagged next week to talk through like beginning of commitment through end of commitment, just to talk about how the services parallel each other and if there's room for additional connections. I think that's where we're at right now. We've got a little bit more work to do, but I feel like we've got a lot of ideas.
Thank you, Cassie. Any questions? Comments?
I would just add one comment that we talked a little bit about training too, because it was identified by patients and families too, that maybe they didn't have and feel like they had enough information about the commitment and about, you know, all that goes along with a provisional discharge and who's responsible for what and managing that. So we talked a little bit about CIS trainings and that bring people together from the counties and placements and the hospital and everybody. It really is that integrated, and that's what's needed. So we talked about training all case managers again about, because it's been a very long time since we went out and did trainings about that. So that was one part I'm sure we're going to talk more about too.
Do you want me to walk through the parents?
Sure.
Family and, okay. So this is not a beautiful PowerPoint at all, but it was what I could do in terms of having to download the data from SurveyMonkey. So as you can see, we've had a whole lot more people with mental illness who answered the survey than actually family members. So you go to the next slide. Then we wanted to see where people were from, and so it's kind of interesting. So as you would expect, you know, a fair amount from Minneapolis to St. Paul, smaller from rural Minnesota, got the suburbs, and then some of the major cities in greater Minnesota. So, but I feel like we got at least some information from kind of all over the state. Next slide. I had to do this because there was an error in reading. We had a staff person enter like 100 survey information, and she misread something. So 46% of the people who answered were white, 25% Black, and then just very smaller percentages in terms of Asian Pacific, Native American, things like that. So we wanted to find out, so what service did a person use before they got committed? And so you can see large percentage were on medication, you know, not quite 40% doing therapy. We had a couple of people who had CADI, ARMS. Some people had been in residential treatment or inpatient. Not very many had used mobile crisis services, not many for ACT teams either, or for clubhouses or for first episode of psychosis. A little over 20% were in a group home, smaller in supportive housing, and other was people mentioned things like halfway houses. Some actually were in prison. They were in their own apartment. They were receiving CD treatment. They were in jail, or they were in a board and lodge. So obviously kind of a variety, but a lot of people were receiving something.
Sue, can I ask a question on that? So do you think that some of that is, I think there's so many acronyms and so many services that feels duplicative that maybe they didn't know what services they really had. Like they had someone that checked in on them and okay, but that could have been an ARMS, it could have been an ACT, it could have been, it could have been all kinds of things as to why there was lower percentage of people who engaged in those services.
I think it's possible, but we know we also don't have a ton of ACT teams.
Okay.
I mean, there's a whole lot more ARMS providers, but there's not a ton of ACT teams. So that I think feels a little probably more real. that not many were on one. Caddy waiver, again, people probably might not know that acronym, but
Is there just general case management up there too? Or maybe I'm,
we did not put. case
okay,
management.
all right,
Yeah.
thanks.
Then we asked, so what might have prevented people from coming in? And I just did a word cloud so you can kind of just see which words kind of, came up the most. But in just going through all of them, people talked about, there've been better medication, fewer side effects, more effective medication. People had trouble accessing therapy, certainly early intervention. People said, I didn't know much about mental illnesses, either for myself or my family member. Support to stay sober. Some people have been evicted from the group home. Some, wish they used more mobile mental health crisis. Some people said a job, just someone to talk to. First episode of psychosis programs were mentioned. Someone wanted a support animal. I think there's loneliness involved because people talked about a friend or someone to talk to. Involving families in the treatment plan. And then this is one that we hear from everyone, is that the staff in these group homes, which are basically corporate foster care settings of 45 people, are just not trained on mental illnesses. And so that led to frankly problems and not enough de-escalation training and things like that.
So can I ask, just, was there any distinction when talking about the group homes, the DHS licensed versus the small assisted livings?
No.
Okay.
Yeah. And then what barriers did you face when trying to access treatment and services? So you can see a huge one is waiting list. That's almost 50%. And we know that that's true all over the place. Insurance not covering treatment, limited in-network providers, no culturally specific providers. That was over 20%, about 20%. Police wouldn't transport someone to the hospital, which we are seeing as a bigger and bigger problem every single week, to be honest. The calls into our office. No hospital bed available, almost 30%. An assessment for waivered services was going to be too long. Some other things that people mentioned was that they couldn't get their prescription renewed. So they had lost their psychiatrist and couldn't get it renewed. Wait times came up. I'm going to be honest, people weren't real happy with case managers. They didn't find like they were helping them find housing and access to services. I thought this was interesting. Someone put in there, no one understood I needed help. Unhelpful staff. HIPAA among family members, of course, is huge. People living in unhealthy environments, lack of coordination, hospital stays being way too short, and then inappropriate discharges. So I think these are things that we've heard for a very long time. So I don't think anything here was really much of a surprise. And then whether they received helpful information from attorneys or the counties. And you can see almost about 40% strongly disagreed that they didn't kind of get that information. And people complained about, attorneys not returning calls, no one willing to talk to families, some attorneys not knowing the mental health system. And, we all know the large caseloads that people hold, both in terms of the commitment defense attorneys typically as well. So. And then were people able to find information and resources about the mental health system prior to commitment? And you can see, again, almost 40% people said no. One person said it was actually hard to get their loved one committed, and that people actually said it's really hard to get someone committed. And then, I'm trying to remember self-investigation. That people they had to just, go on the internet and investigate it themselves. So, but it was, the disagree and strongly disagree add up to quite a lot. So people don't really know how to access the mental health system. And then we just wanted to know about people's experience receiving treatment at the forensic. So you can see very poor and poor, although, still a fair amount of good and fair. People did talk about staff being rude or not listening to them. People talked about the need for more intensive treatment and trauma focus. And there were a couple of people that said that who had been there a long time actually said that it had gotten better lately. And then I did pull out I was able to just pull out the family members who responded to the survey to see what they said about that. And you can see they rated the experience better than the people themselves. And it could be too, it's like, you don't really want to be there, so you're not necessarily going to rate a 5, which is why I wanted to pull out the family experience, just to see if there was much of a difference. And then, do people feel included in the treatment care and plans? And almost half said no. You know, few said yes, few said sometimes, but I think you can see there was a pretty large percentage that said no. And then you can see length of stay is way too long. Over 80% said it's way too long. And just a few, you know, too short and about the right length. And I think what's interesting is there is a difference between what patients said and family members said. So if we go to the next slide, I think that's the family members, and still had a fair percentage saying, you know, too long, but also a higher percentage saying about the right length. And then what barriers that people face while trying to be discharged? You know, people just said it's really hard to go through all those steps to leave, that, you know, you feel like it's more punishment than, you know, kind of rewarding people for their behavior or work towards it. A lot of people said the treatment isn't intense enough to be able to get out earlier. And then people did not like, oh, thank you, autocorrect, the special review board, feeling like that was actually a barrier for people getting out. And then people's experience with the review board, people really, I mean, this was largely the patients who answered this, was that it wasn't fair, that it was a waste of time, it was biased, that they didn't listen to the team's recommendations. There were a few comments that were positive, but most of it was they didn't feel that it was really a fair process at all. And then what service supports and treatment do people need in order to be discharged? So a lot of people say being more stabilized on medications, group homes, sober support groups, ACT teams were mentioned several times, of course, having access to a psychiatrist, housing, jobs, and therapy. But I think, you know, by group homes being so big, it's like you need a place to live, right? You need a place to go in order to leave. And then we wanted to ask how we were treated were you treated as a patient or as a criminal, 50-50 split here. Some people said, you know, they're kind of always feel like they're being treated with suspicion. People said at first they felt like a criminal, then as a patient. And a lot of folks said, well, it kind of depended on the staff person and how they felt they were treated. I did pull this out too, I believe on the next slide, just how family members rated it. And as you can see, there's a big difference that families felt like their loved one was treated as a patient and a far fewer percentage as a criminal. And then any other thoughts? So there, I mean, I really felt, to be honest, for some of the responses from the patients, kind of this despair, like I'm never going to get out of here. It's really hard to get out. I should have left already. There were a few people, you know, I've learned a lot. People saying, you know, again, discharge needs to be more impartial review. People wanting a voice in their treatment, but a lot of people just saying, I really feel stuck. And I also wonder, like, how does that impact people's like ability to move through, you know, the process to be able to get out too. That's it.
So what were the total numbers of respondents?
Oh, 106.
And how many were each?
About
90. The reading might have been page.
I've actually got it. So it was 85 people with the mental illness, and there was a few that were, so it's a little bit more, 90 with a person with the mental illness and 17 family members.
That's sort of reflective for our general patient population and the engagement of their support persons as well in their treatment. So I think that's a pretty good.
And I think these are, I mean, there weren't really any comments that surprised me. I mean, when we look through this data, it's like most people think it's too long, right? I mean, we know a lot of the barriers to accessing treatment and things like that. So I wasn't really very surprised by the answers.
Any questions, comments, thoughts?
Thank you to the folks that compiled all of that, kind of put it into something that we could look at on a more aggregate basis. I know there was a lot of work that went into that.
Sue?
Yes. Liz in my office.
Sue, this is
Yeah.
Sheila. I was wondering, were any of those surveys from people who've been discharged?
I wouldn't know.
Oh,
No, no,
Oh,
the person, yeah, the persons with mental illness, they were all largely from our facility.
Unless some, I mean, unless they participated on the NAMI site, if we had it listed there too.
Yeah,
Okay.
we just wouldn't know. Yeah, we didn't ask that. All right.
Yeah.
Well, we'll kind of write it up in a way to be able to put into the report, but, I'm just pulling out some of the.
After we have open mic, we may have even more to add.
Oh, yeah.
Can I say something? I missed participating in the survey only because I kind of, when it was sent out, I didn't understand that it was gonna be for something greater. I just understood it was just some knowledge the facility wanted.
Oh.
I didn't understand. I'm just telling you that. I didn't understand what it was being used for. And that's what I did ask some people. I never got that. So I'm just saying that's why.
Sure.
Okay.
No,
And
that's
I
fine.
would have loved to, but I questioned it and was like, didn't explain what the data was gonna be used for. I'm sorry. Thank you. I saw you at that.
Okay, well, not hearing any other comments or questions. Thank you again to the two work groups. We will need to make a decision on next steps, however, because we do still have a lot of objectives that we need to be working on. Objectives 3, 5, 7, and then 8 and 9. And what Sue and I were discussed this actually outside of the meeting was that perhaps we could have one group work on those objectives together and then maybe bring the recommendations back to this group. So I know that.
I was gonna say, kind of think about it as, you would have the drafting group basically, because the next steps are supposed to be, drafting some legislative change, some statutory changes. And so that could be kind of the drafting group, and having redone the Commitment Act before as a huge group. I think that, if there's a small group, we can just go through it, thinking about, we probably want to schedule it just a little bit later and let these other two groups kind of finish their reports, because we're going to look at their recommendations as well. And then we can just go through the statute that relates to MI&D or the definitions, and just go through to say, okay, what do you think about this change? And try to come up with some, kind of essentially a bill, if you will, that people can agree to, and then bring the draft back to the full group, because I mean, truly writing legislation with a group of 20 people is not my idea of fun. It's good to have something drafted and then bring it to the full group, if that works for folks.
Yes.
Other thoughts from folks here?
Because when you look at some of the changes, it's like there's, two kind of very specific things to look at. And so it seems like it should be part of looking at that whole part of the statute.
I think as 5 and 6 finish up too, we've touched a little bit on 9 at times, so I think we had some feedback.
Yes,
That would be relevant.
yes.
So if the other, sorry, go ahead. So if the other two groups can kind of try to finish up, but then we can start to work with the next group.
Yeah, because the rest of the objectives are really looking at statutory changes. So we thought might as well lump those together with one group and then bring the suggested changes here. So, okay, so we shall go ahead and do that. I know that there were folks identified for specifically objective 7, and I'm just gonna list them out and then see if others want to join and or if we're okay with that group.
And if those still want to be a part of the draft.
Bigger question, yes, if folks still want to be part of that. So right now we have Doctors Audie and Heath, Ann Zimmerman, Michael Bigelow, Dr. Amber Lindeman, myself, and then Robin, Sue, and Becky Robinson and Megan Larison. Anyone else would like to join that group, or do we think that's a good enough size? That'll be the group doing all the drafting.
Yes.
I'd really like to be a part of that. Great, you could. Thank you.
And if there's folks that were mentioned that don't want to actually draft, but want to look at it later, now's the time to say, you can remove my name.
Yeah.
I just wanted to, I think objective 7 and 8, you know, I think we were waiting on some other information before we even finished our conversation. So to me, it's like, I feel like that group should have some conversations, hearing what 5 and 6, like what the other feedback has done before we can jump into drafting a whole thing. So I don't think there was enough agreement amongst all of us on certain things yet to start drafting something. At least that was my perspective. I thought there was still more discussion to be had, so.
Oh, that's why I meant those other two groups need to finish up and then we move
Okay.
to that. Yeah.
I don't know when the next meeting is. I don't know, maybe it's in there somewhere.
I think we just had a,
Yeah, we haven't,
we just had a doodle.
a lot of the people from 7 joined 5 and 6.
Right.
For the last couple times, so
Mhm.
I guess I kind of thought that was already happening.
Okay,
But I know 8, we have not talked about 8 yet, so I will
Okay.
get that scheduled.
okay.
It'll be in March.
Oh, wait, but 8 is statutory changes, so we're not, that'll be a.
8 and 9 will be like.
Oh, well, so we're gonna put 8 and 9 together, so.
Right, because if you're making changes to the
That's
statute,
fine.
doing them separately doesn't work. You gotta bring people together to look at the whole thing and the changes that need to be in it. It just, otherwise, you've made a change and then this other group's made a change
Right.
and it's, yeah.
So would it be safe to say that we're disbanding that work group? Because
So-
7 is joining.
So what I would say is we've got our 2 groups that
Okay.
need to finish their work. And then we start the drafting group that will develop the recommendations based on the other 2 groups and those specific requests.
Just wanted to be clear.
Yes.
I'm not gonna call an unnecessary meeting.
No,
Yeah.
no, because you can't break
Right.
up during the statute like that. It's
Right.
just For bill drafting.
We're learning.
No, but no, I agree with you,
Yeah.
that we've got to have
Yes.
those other
Okay,
two
'cause
groups.
we have, yeah,
Still have other data.
I think objective 7 still needed some work, so.
Yep. And Cassie already has a doodle pull out for our next meeting, so.
Okay.
Okay, well, thank you. That was easy. And I just want to thank everyone. I know you all are involved in quite a bit of work outside of this meeting, and I'm hoping to continue with that momentum as well, because that's needed. It's a pretty, this is a pretty important topic, and we want to make the right changes at the right time as well. So thank you again. Do we want to take a quick break? I know we're a little bit early, and then maybe we come back in 10 minutes and then we start with our open mic session.
Sounds good.
Okay. All right, we shall
just, I mean, I don't think we'll be done at 1:30, but we'll just stay a little bit later in case people, are trying to get on. If that makes sense to people. So we wanted to make sure we had an opportunity for, both patients and family members to come talk about their experience and the barriers and kind of the Clip Notes version of their stories. And so we'd like to go ahead and invite people to, there.
About sharing. I'm sorry. I'm sorry, Megan has it.
Yeah, so if they just wanted to come up to an empty chair and kind of share their story is fine. So if anyone wants to start.
Before, just a second.
Oh,
Yeah.
What?
You want to start?
I'm sorry, what?
Before we get started, we do have a note from Megan Larson.
I just wanted to note for everyone in the room that this is an open meeting, which means it's publicly available, it's being recorded, and the recording link will be on the website. So be mindful of that. If you're using identifying information when you're talking, you might want to revise what you say or not, but just be aware that if you share specific information about your loved one or someone with lived experience, that it's going to be available to the public. We're not closing the meeting for this portion. That's all.
Thank you. So would ever like to go first? Come on up to the one of the.
And I'll be the timekeeper, and at 4 minutes, I will raise my hand. So you'll know you have 1 minute left to wrap up.
And if you just want to state your name.
My name is Anne Marie Brass. Okay, I'll go quick. I talk fast. What actions led to the MI&D? My son did not have a safe and supportive environment in his group homes in Hennepin County. He had to ask a roommate to get him to North Memorial for a voluntarily admission, where he stated 5 times in the ER and in his records on the medical floor that he had not slept in 3 nights, and his voices were telling him to hurt someone. They released him with no psychiatric admission, no notification to caseworkers, no notification to even the group home, the task program he was in. No notification to doctors, no notification to anybody. 5 times in his records, it states he was there because his voices were telling him to hurt someone. The system let him down. He had no psychiatric stabilization. 3 days later, I don't want to skip it, did something. And anyways, that's what led to his MI&D. The hospital, I think, had assumptions he had support. With cancer. Trying to think. Okay, I should skip past this. Okay, what services could prevented better group home staffing? Found out someone was only there 2 times a week with 8 psychiatric patients. Both group homes, the other one he was in Brooklyn Park. His roommate stole stuff. It was a scary situation. He was afraid he was going to get murdered if he reported anything. Poor supervision in these group homes, just really poor supervision. 2 times a week with 8 psychiatric patients, male and female in group home. I will never assume care in a group home ever again. I will never assume he was getting care. Okay. What's happened? The group home said, okay. He has had poor diabetic care at St. Peter, and I know I heard it's based on national standards, rules, federal government, but no continued glucose monitor. He has comorbidity. He was a men's small. He's now 250 pounds. And for a diabetic, that's really, really medically cutting his life short. And nothing can be done about it according to rules and regulations. So not only meeting my son's psychiatric, they're cutting his lifespan down with not meeting his diabetic care. And that's major. And not only for him, it's the same thing for all patients at St. Peter. There's many with diabetes. Okay, I'll skip really fast. What community service could have helped? First of all, and this has been told to me by the heads of University of Minnesota psychiatrists, I've talked to them. The one thing they wanted me to pass on for even last year, I know where to say it. They cannot get records out of St. Peter. They cannot get records out of St. Peter. And this is told to me over and over again. I hear this. They say it's a bottleneck because they cannot find continuing care with both medical and psychiatric on the patients because they cannot get records. And the continuity of care is not there. Okay. That's really bad when the psychiatrists feel lost because they can't get records. Okay. The one thing I got to skip really fast. One of the things I want to talk to you about is really quick is employment and life after St. Peter. First of all, it's a bottleneck getting out, just like the survey said that. The other thing too is I would like a better environment. Number one, there's NIH study about employment is critical. I'm trying to go fast. The employment is very critical. And if unemployment worsens mental health and employment improves mental health. I have the documents and the studies to read, but it is in the NIH. It's called Epidemiology and Psychiatry of Sciences. And basically it is the only intervention, employment, that lessens dependence over time. Supportive employment decreases use of psychiatric hospitalizations and reductions in mental health costs. And that's just the main gist of it. And this is a study that's compiled. Okay, and then I'm probably run out of time, but
You're okay.
I'm trying to say as fast as I can. Anyways, the biggest thing every parent and loved one wants for their child is for them to have employment somehow in life, have employment. So they feel like if they pass on, one of the things I hear through all the support groups is we're afraid of what happens to our loved ones if we die, because most of us are older and things like that. And to know they're in some kind of employment. My son, I haven't heard anything at St. Peter, like what they do afterwards. Okay, not gonna have to, but I hear nothing. You know, some of the things, there was just an award for a movie where they took the guys out of prison and they had them be the firefighters. They trained them. You know, I talked to the DNR myself, the head of DNR, and I said, why can't you take some of these people at MI&D? Maybe they could go out, plant trees. Maybe they could work in the fisheries. Maybe they can do something. If they can't get employment in the private sector, why not look at employment in our own government system, even though I know they're cutting everything. But you know, I mean, non-stress jobs, but that sounds, I've talked to guys, they're like, that's great. You know, work for the DNR, do something and make them feel like they have something. My son does not want to be released and get into a program and sit in the basement at the bottom of Riverside and some outpatient depressing program in the basement. He wants to get out. He wants to be free. He wants a job. He wants a college. You know, you got to realize some of these people went to college nowadays that are coming in there. They're just not high school grads. Okay. They want something challenging. You know, it's sad, but anyways, that's it. The other last thing, I'm just going to not read it, is a better environment in their living situation. One of the things I thought about is everybody wants dignity, living in their own space. My son has stuffed stone group homes, can't do this. They want to be able to lock the door. Sure, somebody else can have a key to it, but maybe have like a nice apartment complex with studio apartments. I heard they're having something like that in Minneapolis, where their own little studio apartment. They can fix their own food, where they just, my son said, the most important thing is I want a place where I can have my friends over, not psychiatric friends, and sitting in a psychiatric group home and sitting in a place. It's depressing for them. If they get better and want to get out, they want to be like, they want to have their other old friends back. They want to feel like something. So the environment throwing them back in these group homes where that's how they got in there is, to me, you're sending the cycle back. And there's a lot of people recycle back there. But if you give them employment, you give them a good living environment where they feel they have their own turf. You know, where they can feel like they're not just sticking in psychiatric. Like you could have a facility step down from St. Peter. I mean, you got to go, but it's going to cost less. It's got to cost less than $30,000 a month, and have them feel like they got their own little studio apartment. You know, where they have a bed and then they have a little living area they can have a friend over. Not sitting in a group area. I'm done.
No, you've got a minute.
What?
That was just your 4-minute warning.
Okay. Well, anyways, I had so much to say. But, you know, I think those are the two main gists of it. And my son never grew up around violence. He grew up in good environments. He went to good schools and he died. I'm not saying anything, but he was in good environments. There was no violence until that point, till his voices told him if he didn't hurt someone, he was never going to see his mom again. That's what he told the police. And he voluntarily showed up at North Memorial. voluntarily had to have his roommate, no group home people, show up at the hospital. And in his records, it states that, what does he do? You know, so, and he needs a new life and he needs a chance because the system failed him. He went for help and the system turned him down. Okay, I'm sorry, thanks. I talk fast and loud.
No,
I'm Italian American, whatever, because I'm shaking. Because
No,
thank you.
no.
Thank you.
Nice job.
I hope you listened to that. I wasn't a part of the survey, I missed it because I questioned who was using it.
Oh, it's okay. We're gonna take that information.
Thank you.
And the program that you're mentioning in Minneapolis is Rising Cedars. Is the
Okay.
one where you have your own apartment.
Yeah.
But services and supports.
Yeah, I heard, the only thing I heard from, University of Minnesota social worker was that just the medication issue was the only problem there. That's what I heard from her.
Oh,
I
no,
don't
they
know.
have nurses on site.
But I don't, whatever, yeah,
Yeah.
I don't know. That was just something I heard, but it's not.
But thank you.
Thank you very much. Thank you so much. Thank you. Sorry, to talk fast.
No, it's okay.
First, I would like to thank all of you here for the time and effort that you have put into this very important situation that all of us are facing. And especially thank you to Anne Marie for bringing up employment and some of the issues that you brought up. So, my name is Kathleen Fischel-Beto. My son was diagnosed at 11 years old with Asperger's in 1994. That was differentiated from classic autism at that time. He also had been experiencing the effects of increasing severity of seizures beginning when he was 9 years old and the resulting outbursts and aggression. After nearly $1.5 million and 10 years of intensive neurological medical care, the focal point of the seizures was discovered, and at 18 years old, he underwent surgery to remove a tumor in the temporal lobe of his brain and the entire right temporal lobe. After that, his challenging behaviors increased significantly, and for him to receive services, he needed to live in a group home. We knew almost nothing about group homes, but we knew one of the owners of a group home that was close to our home, and we continued to be involved with our son. The actions that led to our son being committed were due in part to the neurological damage he suffered, but also due to the lack of competence, knowledge, and English language proficiency of the staff members in his group home. The misunderstandings that led to my son believing that he was protecting himself rather than his acting out in an aggressive way that landed in violence. We know that he has a severe neurological condition, but we also hold him accountable for his behaviors. This is another constant challenge. After serving just under a year at the Hennepin County Workhouse, he was committed to St. Peter from the time he was 19 until he was 32 years old in 2015. He went back to St. Peter voluntarily in May of 2024 for help he realized he needed, and then was released after his 60-day voluntary stay. Our experiences at the forensic hospital have been that we are left out almost completely of any participation, inclusion, or information about our son's treatment or learning about what he was experiencing. In the past, we were treated coldly and suspiciously, and I was once told in the middle of winter to leave the visit and go into St. Peter and get a sandwich, and then come back for additional time, despite there being no one else visiting and having the right to stay for another hour. I questioned why this was a demand by the guard and asked to have the visiting rules shown to me. There were no such rules given to me, as the guard for some reason had just made up this rule. In deliberate payback for my questioning the behavior of the guard, at my next visit, a supervisor accused me of sexual inappropriateness during a visit when our son reached out to me for a calming behavior that he was used to doing during the years of his extreme seizures and difficult interactions in school. It was not sexual. It was a comforting closeness for a scared patient in a locked and frightening world. It is difficult to describe the feelings, outrage, and fear that cruel and untruthful accusation caused, and is still with me. While this was the most egregious example of deliberately excluding our participation, there were several others. After being left out completely of his treatment for years, we were finally included in some of the therapy work with him when he reached the transition unit. The first place I would want to start with ideas of improvement at the state hospital would be to include the members of the family who wanted to be involved in the mental health care of the patient. Share with us what is being done. Teach us how to support your work.
allow us to participate in a team effort of helping the patient, increase the education, training, and wages of the staff, provide more activities for patients, particularly outside in the grounds, perhaps with physical activity to occupy them during the day when they are not involved in a group or individual section. I don't know much about the community services that help my son move back to the community. No one speaks to us. We are not included or asked to participate in any way. This is HIPAA. Our son is trying very hard to live like an independent adult, and this means to him that he handles things by himself. So we can't offer support or even provide helpful information to any staff or program intended to help him because we don't know who they are or how to contact them. Despite all the negative and very hard experiences we have had at St. Peter and his continuing care, we are grateful that we have a state hospital and that our son was able to receive care there. We want to do what we can to help and support the staff and raise the standard of care for all patients. In a futile effort to have the staff recognize the importance of educating and including his family in the healing work with our son, I said to the staff, please help us understand how to help him, as you'll forget his name in 2 years or less, but he's in our family forever, and we love him.
Thank you so much.
Thank you.
Hi, I'm Cindy Kern. So I just kind of go through Robin's questions here. The action that led to our son being at St. Peter was that he was released from Riverside Hospital after a 72-hour hold. It might have been a little longer, but he was not stable. And the event happened the next day. I believe that more care is needed on the front end. And I think that would help decrease the admissions to the hospital at St. Peter because, you know, they seem to, and this happened in the treatment programs he's been in and at the hospital stays, they always prescribe the same medications and they just, it was the same ones over and over and over that had the weight gain, the shaking, the drooling, pre-diabetic, you know, situation. It just seems like there should be more options explored. Some of those medications to be sent home on, it, you know, and his psychiatrist at the time described it as having, you know, bugs under your skin. You just can't walk enough and you can't pace enough to get rid of it. And now we know, you know, that our son is on a medication that doesn't have those side effects. So it would have, that would have been a big difference for us. I think that the services that would have been would have prevented our son from being sent to being committed would be early education. You know, it's more than just getting, you know, the book. I'm not sick. I don't need help. That was kind of what we got. And yeah, I mean, these parents, ourselves included, needed to sit in a room and watch movies, and we just were so unprepared for the journey that we were embarking on at that time. So I do think there needs to be more education. There seemed to be a focus on a diagnosis rather than the symptoms. And all of that was just really difficult for us. So my son's been at St. Peter for 6 years now. And he, again, which was both ladies mentioned previously, there's just way too much downtime. You know, if they could have like a real fitness schedule, it's so needed there. I mean, you can look around and see that these people do need to exercise, and it's got to be more than just a short walk in a little caged area. They need to have, you know, some aerobic activity, and it should be daily, I would say. Let's see, our experience at St. Peter, though, is on a positive side. He is now on a medication that has allowed him to become stable. He's accepted it. He's totally open to adjusting the medication. He wants to work with the doctors when he can. And, I guess the communication has been a problem for us too. The unit staff seems to be very dismissive both to us as family members and to our son. I do think the communication would be really welcome from family. The treatment notes seem to be a really, big deal when it comes to going before the SRB board. And, we have found them to not be accurate in many cases. And then there's this cutting and pasting thing that happens over a period of time so that what they're looking at and says recently actually happened 3 years ago. So, no matter what they do, when they get before the SRB board, what they're seeing is recently he did this. Well, actually recently he'd been really good for 3 years, but there was that one time that happened. And so, you're dismissed. You don't get to move on. So, I am excited to see that this task force has been created because, it brings some of this stuff to the surface that, I think, if you don't acknowledge that there's a problem, you can't fix it. So it has such a huge influence over our lives. You know, and I would just like to see, again, more health and wellness, more positivity, more goals and achievements, measures of goals and achievements for them. There's some institutional stuff that seems to happen in certain units with check-ins, and it seems to be more about obedience. I would like to see the quarterlies because they take up so much time. They should have more meaning. They seem to be repetitive, and that would be such a great place to have some goals and achievements that, maybe they could get some positive feedback from those. I would like to see, this is what you're working as a supervised next step that would not be so difficult for the board to let them go because they wouldn't be in such a risky situation. It just seems like, right now, and we've never been in a group home, but from what I've heard about them, I'm not too excited about that. I don't really know much about it because we haven't been in one, and maybe there are some really good ones, I'm not sure. But it would be nice to see that there was a place where the SRB board could discharge people where they wouldn't feel like they were taking such a big risk. And again, as a family, we have had a devastating experience. And all we really want now is effective care and meaningful recovery for our son. There's no question that he's better, but he has been better for years. So, these people that are there that we're here to talk about deserve a second chance to show that they are good people. And our son was in this Davis, unfortunately, when his world changed. And he just wants to be back in society and be have a useful life and also, anything that he can do for education or a job he's tried to do while he's there, but it's been very minimal. So yeah, that's about it, I guess.
Thank you.
Thank you.
For waiting for me.
Oh, of course, Connie.
A little bit of a delay. Hi, my name is Connie Kishel. I do recognize some of you. Thank you for giving us an opportunity to speak our piece and to be heard. Focusing on the suggested topics. Well, first of all, I have an adult son down at St. Peter.
As I will mention, he has been down there a good 14 years, which is unheard of. Anyhow, focusing on those suggested topics, in our case, the MI&D label or placement was given during court. And there was a lot of discussion because my son had a bit of an unusual background. He wasn't directly committed MI&D, but had some behaviors that indicated that that could be the case. They even had a lot of questioning and discussion about his diagnosis because apparently it didn't line up according to their plan and what fit in. So after a lot of discussion, they chose an MI&D commitment. My son actually also requested that because he knew he had been leaving group homes and he wanted some help. And so he did make that suggestion or make that known. However, I guess we all didn't realize that there was an undetermined end to that commitment, which it could just take my breath away. Later on, I did hear that there were 6-month commitments, 12-month commitments, and it sounded to me like a matter of just setting up a deal for 6 months or 12 months. Otherwise, you may be sent to St. Peter. I don't know if that would have been successful with him at the time of his illness. But as I said, here he is 14 years later and not originally determined MI&D, but kind of scooted in. Another issue, could that information have been given to me by the attorney, by some legal papers that were given by the court? I later did find out through NAMI, but unfortunately, I hadn't been connected at that early point. But then I did hear about commitments through NAMI later. Some of the patients, I was told, feel that generally the staff is quite supportive. They feel that the staff wants them to succeed. My son pointed out if his one-to-one does a good job and my son succeeds, that shows success for the one-to-one too. So he said generally they are supportive. There are a few, he considered that with an arrogant attitude, maybe kind of a bullying situation. And you realize that happens in many situations, but I would just suggest that there be further empathy type training for all staff, especially those working closely with the patients. And then continuous observation, of course, of the staff. Further, I would like to encourage staff education related to family communication. That's been mentioned a couple of different times. I do feel that is limited. It's been kind of limited in my situation. There's not a lot of information from either the social worker or the unit. You do feel like you kind of need to beg for that information. And I think the staff needs to understand that this patient is just not a lone person. He's part of our family. He or she is part of our family. And so that communication is really important. I would emphasize working with families. I'd also like to see a little bit more consistency within units. There are some units that are very strict, others not so much.
They seem to have a bit more of a subjective attitude. And so it's kind of confusing for the patient to see these different levels. I would like to reinforce what has been talked about, encouraging physical activities, perhaps a little bit more emphasis on recreation therapy. They seem to be the ones that are able to provide activities for all of the much off time that they have. And also I do agree with the fact that sometimes patients' past is a little bit more emphasized than it should be. And that can be quite downturning for the patient too. If they always see what happened 10 years ago, 14 years ago, that to me is irrelevant. They were very sick then, but the progression and what they're showing now is of most importance. So again, I just want to thank you for this opportunity, and I wish your committee success in this task force. Thank you.
Thanks, Bonnie.
Hi, my name is Sarah. For those of you that I haven't met, my son Louis is at St. Peter and he's been there for about 8 years. What led up to him being committed as mentally ill and dangerous, similar to stories that you've just heard, was undertreated and 72-hour holds, left with medications that he wasn't going to take. Even if he had taken them, he wasn't prepared for the side effects. Long story short, he was threatened with having to go back to another 72-hour hold and was scared, and he punched his guardian at the time. I feel like as far as things that can be done before, like you've already heard today, education, family education, even the professionals that I worked with leading up to the commitment, I didn't feel had enough education to even educate me and our family. I had an attorney tell me that that I shouldn't be his guardian. Once he was at St. Peter, there was nothing that I could do for him. And I found it to be extremely helpful as far as communicating with his team. So, I mean, if I would have listened to that attorney alone, his story would be different, I feel today. He is in transition, which is super exciting. I think I do say often to people that it's unfortunate what led up to him getting to St. Peter, but the help that he's gotten there, he wouldn't have gotten anywhere else. To have medications monitored, the nursing staff, the doctor staff, all of the staff at St. Peter, he wouldn't have that anywhere else. I think that that he needed all of that care, and I think that has helped him to be where he's at today. I do appreciate the tears, and I don't think that's the right terminology, but I appreciate that he has to show over and over and over again before he gets to another level. Because for my son, I feel like that's important, because I think that to practice that and to have to show that, I think that that's important. And just like we've heard already today too, the staff, if you ask Louis, or when I do ask him, but have you talked to staff about it? He's like, no, they don't care. And so I think that the educating the staff that work with the clients there more can help more. So I think that staffing education is extremely important for the people that work on the units with the clients the most. Um, I think that, also like you've heard today, family is important. I talked to Lewis a little bit about what I was doing today and, he said, make sure that they know how important family is. He says that he appreciates his family support. And really lastly, as far as, community services for after, uh, I don't know a ton about what's gonna be next when he gets to that point. But my hope is that there will be something that, compares to the supports he's had at St. Peter. I mean, he is an athlete, he loves the gym community, he loves church services. He loves the activities, he loves the social stuff. I hope that's there for him when he gets to the point of his next steps. All I have.
Is there?
Thank you.
Good afternoon. My name is Rob Kern. And you've already heard from my wife. So some of this will be a little bit repetitive. But I'm going to start with our initial exposure to mental health. My son, as my wife has mentioned, attended Gustavus College in St. Peter. What a coincidence. It was February 12th, 2013 that he left the college in a high-speed chase. Never was caught. Came to our home. We harbored him because we knew nothing about mental health at the time. He had been an honor roll student at a private high school, and he had received an honor roll in his first semester, as well as being an outstanding football player for Gustavus. We harbored him or controlled Cody from that date, February 12th, until August 28th, 2019, when he arrived at St. Peter. During that period of time, our family invested $1.5 million in 6 treatment centers and 15 hospital stays. Our first hospital stay, he was taken to an emergency room in Chaska and held in an emergency room for 2 days. They finally said we could move him to Cambridge. He left and went in a hospital or in an ambulance ride from Chaska to Cambridge. He was there a day and let go. As they counted those first 2 days at Chaska as part of the 72 hours, where he received zero help other than sitting confined in a hospital emergency room. He went back to school. We met with all his professors because he went a week late. We talked about the experience Cody had. In April, he left that college again in that high-speed chase. He was then brought to Riverside Hospital on another 72-hour hold. And when we left that 72-hour hold, finally, with actually medications for psychosis. The hospital in Cambridge only gave him medications for anxiety. So when we left the hospital, we got a bag of pills. And the pills caused everything that my wife talked about. Shaking, drooling. He didn't understand the pills or the medications. We didn't understand the pills or the medications. And we sat like this for 72 hours doing nothing, where we should have been learning about the incredible journey that we were facing. We had to learn it on our own. No one in the system helped us. So we did it 15 times. You would think by that time, someone would have been able to give us some help. And 6 treatment centers. The last treatment center he was at was 17 months in Evanston, Illinois, where we paid over $300 a day to have him there. And while he was there, the last 6 months, he cheaped his medications. $300 a day, and he cheaped his medications. When he was returned to us in September of that year, after not being on any medications for 7 months, we had to bring him to Riverside Hospital again. This was the 15th stay. He was there for 7 days. The hospital told us to come and get him. Now, we had been there many times, so we knew the routine. So my wife drove up to the entrance to the hospital, and I went up to retrieve my son. And I walked out of the hospital with 2 armed guards. And as I put my son in the car, I said to those armed guards, "Are you coming home with me?" The next day, he stabbed me 7 times. I was in the ICU for 7 days with 200 stitches. Now, that's 1 and 2. Something needs to be done about that. That was 6 years ago was the last time we were in a hospital. I don't know if the 72-hour program has changed at all, but God hopes it has. Now, Cody has been at the hospital, as we said, for 6 years. We arrived at the hospital on the Elm unit at a family meeting and discussed his background with the hospital. We discussed his diagnosis with the hospital. We left the meeting in St. Peter and immediately drove to the Associate Clinic of Psychology here in Minneapolis and signed all the releases so the hospital could obtain his records. Because he wasn't just schizoaffective, he was autistic. Did they request that document after we asked them? No. When we were on the Bartlett unit 2.5 years later, we asked that unit manager and that treatment team, where's his autistic report? We don't have it. They didn't believe he was autistic. They were so disruptive about thinking he was autistic, they hired, and I'm talking about Minnesota Security Hospital, they hired another psychologist from the Department of Human Services to conduct an evaluation. I don't know why, they already had one from a credible psychologist. But their psychologist, Naomi Watson, or excuse me, Naomi Nystrom, after a 2-week period of time interviewing both Cody and my wife, confirmed Dr. Foster's report. That shouldn't be the case. You should listen to us as family members. We live with this person all our lives. We know what's going on. We see our son every week. We talk to him twice a day on the phone. We're a tremendous source of information. So how are we treated? He's presently on the Fraser unit, and the people on the Fraser unit intimidate us. When we're sitting in the waiting room to go in for his 90-day review, they bring 2 armed guards in to escort us. into the room. And I said he's been on 15 units. The first 14, my wife and I spent 30 minutes on the 90-day review. Since he's been on Fraser, to intimidate us, they allow us 15 minutes. Our visit is cut in half. So we drive 3 hours for 15 minutes. Think about that for something that could change. My son was an athlete. He's an exceptional football and hockey player. He may use the facilities for exercise at St. Peter maybe once every 2 weeks. But it's like the Charlie Brown comic. You get to go on Friday, Cody. They tell him that on Monday, and when Friday occurs, you can't go. Think about that. Now, finally, I will mention to you, and Sue, you know this, that I worked with Dr. Vinograd at the University of Minnesota. I have a group of people who are investors. They are as set as iron at the system. We have found property that we are willing to build something that can be supportive of discharged MI&D patients. We would help fund it, but we need somebody to help support the system. And I've raised my hand for 3 years. You know how many people have asked me what they would be willing to do to help me? None. Thank you.
Thank you.
Is there anyone online that wants to speak?
Somebody joined Carmen. Carmen just wanted to listen in, unless she's changed her mind.
Can you speak louder, please?
I just wanted to listen. Thank you. Thank you for offering.
She just asked if Carmen wanted to speak, and I said Carmen had reached out to say she wanted to listen and support others, but she didn't want to speak. But are there others that would like to speak?
This is Sheila. Can you hear me? Hi.
Yes.
First I want to give amazing kudos to all the family members that spoke. I think it gives our committee just a wealth of information and it personalizes our whole agenda here as far as what we're tasked with doing. I also want to bring forward again, and it's been discussed already, but I there's another family member who couldn't be with us today, but I'm going to speak on her behalf. You know, she's really brought forward this idea, and it was mentioned in some of our group, I think work group 5 or 6, that something needs to be like an area where there can be a longer assessment. As Rod said, 72 hours in a hospital, that really virtually does nothing. And that's been my family's experience also. That how do you find a medication and know if it's effective in 72 hours? The answer is you don't. And then they're discharged and you're back on the same merry-go-round. So if someone ends up in the court system, why do we have to go from the court to St. Peter? Her suggestion, and I heard another person, I don't remember his name, on the committee who also brought this forward, having some sort of an interim place where an extensive assessment can be held. And from that assessment, which could be maybe a year a year-long assessment. And then if that person needs to go to St. Peter, so be it, or maybe alternatives to St. Peter. If we're looking at trying to keep the numbers down so people who really need to be there can get in, this to me seems like a really viable option. And I know this all boils down to funding and, but it's also kind of what, excuse me, Rod alluded to. Anyway, that's all I have to say.
Thanks, Sheila. Anyone else?
My name is Cheryl, and actually my son is in Parkland right now at Ramsey Adult Detention Center for criminal offense of arson. And been deemed mentally ill and waiting to go to St. Peter. And that's why I came here. I've met wonderful people who want to help solve this broken system. And I have been educating myself, been in NAMI groups, been with University of Minnesota, of course, that closest for 4 years. My son has been mentally ill for 10 years, depression. He managed to get himself into the Army, went to boot camp. And if you can imagine what boot camp does for someone, just the physical activity and how healthy that is, and how we hear sleep, physical exercise and good food and medication is how someone survives the trauma, mental illness and psychosis. I didn't plan on saying anything because I couldn't understand the first question you people asked. How did my loved one become mentally ill and dangerous? Mental illness is not to blame for any of this. I mean, it is, but my son is not. Because mental illness, what it is, it's, something that is not his fault. In some ways, he's an addict. He's tried to, connect with people, tried to go to treatments, in many centers and kicked out. And we just couldn't leave him on the streets. So we brought him home. He was an addict. And we didn't know where else to go. There was no place that was helping. And he's been on and off medications and he's in jail. And he wants to go off his medications again. If you know what anosognosia is, there's many people who don't believe they're sick when they have psychosis. I don't know what is going on at St. Peter. None of it sounds good. I talked to a lawyer yesterday, just want to get feedback on what it means from his Rule 20, mentally ill, not guilty for the crime. Next one, mentally ill and petition to get mentally ill and dangerous. And so now his lawyer is saying, gee, he should wait until he has a couple more evaluations. And I'm under the impression that it's people at St. Peter, psychiatrists at St. Peter, who are interviewing him to determine whether he is, after a 90-day waiting period, truly mentally ill and dangerous. So the D may go away if he goes to trial. Not thinking that's a good idea. Someone down in the mental health department at the jail suggested because he's like, I've been here a year. When will I get to St. Peter? Do you know what kind of help he's had in the past year? 0. He's not been outside for a year. And it's jail. I get it. He did a horrific thing. But none of that makes sense to me. I just can't imagine someone who's never been outside. He used to walk his dog daily, 5 miles daily, and he's not been outside.
I'm sad. I don't know how it'll be in St. Peter. Lawyers tell me that he's not gonna get a D off his, diagnosis or whatever, his record. So, don't go to trial. And he's already waived his rights. He wants to get to St. Peter to get help. He truly wants to get to St. Peter to get help. His cognitive ability is gone. He has been suffering and trauma with his mental illness, his addiction, I know it's his fault. Yes. His addiction is all of this is his fault. Really? No. It isn't his fault. Don't ask those questions next time. We need to help. We need to stop. I'm in a group. These parents who have kids that are suffering from psychosis now go to the hospital. Nobody tells them anything. They leave there with nothing. You could give them a book from the LEAP system. How much has that taught me about just listening and being empathetic to someone with psychosis? Do you hand that book out to everybody that works at St. Peter? Because I'm sure they could benefit from that, just listening, being empathetic, because it's not their fault. Something snapped. You get cancer, it's not your fault, right? Am I wrong? Are you telling me that this is his fault? What made him mentally ill and dangerous? What kind of question is that? People laugh at that. I'm in a group with cops. They're like, who would ask that question? And back to the suggestion from the mental health person. How can I get out of here so I can get to St. Peter faster? Go off your medication. They'll take you to another. Finding out my son saying, I don't think that's a good idea, Mom. What do you think? I'm just like, I don't know. I have no idea what that means. What it means is that he'll be triaged there and he'll be put on medication. He has a Jarvis order. He'll be put on medication and will be brought back to jail. He's waiting. He's number 14 to get into St. Peter. Move these people along and help them. Help them. The lawyer I talked to yesterday said, I never see anybody get out of there. He's getting there. He's 18, 14, 20 years. Someone has been in there. And I understand. Those are sex offenders. And we kind of think that they're not capable of rehabilitation. This is such a broken system. And the criminal system I get is different. And we're all working really hard. There's a lot of people who are working really hard to fix this system. I talk to them every week. And I haven't given up. So please hear these people. They hear me. We want to help our loved ones. There are people in there that we know. We've known we've known them all their lives. And they snapped something. And I don't know if it was because he tried marijuana when he was a kid in high school, drank. I didn't know that this would happen. And I want to help my future family, my grandkids. I don't want this to ever happen to anybody. And I'm sorry, I wasn't going to say anything, but I just don't want to keep my mouth shut because sometimes. Thank you.
I just want to add one thing to perspective. This was really interesting and I'd like you to hear this. My son is a good kid, okay? He said to me recently, and it kind of put things in perspective with the psychosis. He said, Mom, there was another man inside me. Think of it. There was another man. There was this good person who was there, but there was another man inside me telling me what to do. So we see the one man, he's fighting the other man. But we as family members, we see the good man.
I want to thank everyone for taking the opportunity and the chance to share stories. I know that that's hard, and we specifically set aside time so that we would be able to have a chance to hear from you, because we thought that was an important part of the task force, was to hear from people.
Thank you.
So.
Thank you.
Thank you. And so we don't have any family members on the line, right, who want to speak? No, okay.
So our next meeting is March 24th. So it would be good if the two other subgroups can kind of try to finish up their work by then. And then we can kind of maybe talk about some of the recommendations that are coming out of both of those groups, and that will help feed into the group, and then we'll start drafting for legislation. That sound good to everyone? All right.
Thank you all.
Thank you, everyone.
Thank you.
Oh, I just gotta get my forward findings and certain.